I'm Zvonimir Krajcer. I'm an interventional cardiologist at Texas Heart Institute. I would like to share with you the latest information on current and future landscape of percutaneous assist devices for treatment of acute decompensated heart failure and cardiorenal syndrome. Here are my disclosures that might be pertinent to this presentation. So what are today's percutaneous temporary support devices for acute decompensated heart failure? As we can see here, it's intra-aortic balloon pump, Impella, ECMO, and tandem heart. Let's share some information related on the current devices that are available and depending on the level of systemic flow support for acute decompensated heart failure. And that's related to left ventricular unloading or left ventricular loading. As we can see here, one of the devices that's used for a relatively small requirement as far as systemic flow support is intra-aortic balloon pump, followed by Impella 2.5, followed by Impella CP with 3.5 flow support, and then the latest high generation output for Impella 5.0 for acute decompensated heart failure. Once the requirement is significantly higher, requiring up to 6 liters of systemic flow support, we can use ECMO and in combination with Impella, or we can use ECMO and intra-aortic balloon pump. Now, there are several issues related to intra-aortic balloon pump and other percutaneous devices, and here we can see what are the contraindications for intra-aortic balloon pump. There are numerous, and complications also related to the use of this device. So obviously there are unmet needs as far as this type of devices are used. Here are some of the issues related with ECMO and tandem heart. It has significant complexities and requires high level of expertise for use of this device. And there are numerous complications that we can see here. One of the most common one is renal failure and bleeding as well as hemolysis is concerned. Let's focus on the issues with the current generation of Impella devices. You have to cross the aortic valve, which has certain consequences. It certainly requires precise location in the left ventricle and aorta. It requires frequent repositioning. It has high pump speed up to 35,000 RPMs, which frequently leads to hemolysis. And there are contraindications, as we can see listed here. Now, what is the current use of percutaneous ventricular assist devices in the U.S. markets? As we can see, the mechanical devices are on the rise, as well as percutaneous assist devices, while intra-aortic balloon pump is on decline. Now, what's also interesting across the U.S. markets, we can see tremendous variation as far as the use of those devices are concerned. And also pertinent information is that higher utilization of PVADs during PCI was associated with higher cost, but not with a lower mortality and morbidity. So at the present time, there is no consensus on best practice regarding the use of mechanical support devices or PVADs or intra-aortic balloon pump for acute hemodynamic support for cardiogenic shock or high-risk PCI. So what are the future percutaneous assist devices for acute decompensated heart failure and cardiorenal syndrome? Here are listed not necessarily all of them that are currently undergoing evaluation or clinical trials, but the most pertinent one. As we can see here, related to the mode of action, there are some of them that decrease the preload, and they're called pullers. And there are some of them on the bottom that are called pushers, and they increase cardiac output and renal blood flow. And there are 2 of them, CPNS and Magenta, that also increase cardiac output and increase renal blood flow. Let's look at each of them a little bit more in detail. The Raya by Revamp Medical reduces venous and cardiac preload. It's located in the inferior vena cava below the renal veins. It increases renal arteriovenous pressure gradient, and this increases renal arterial blood flow and improves renal function. First in man, procedure was completed in October of 2022. Precardia, currently owned by Abiomed, is a catheter-based technology that has a proximal balloon positioned in the superior vena cava, and the distal balloon, this is positioned in the pulmonary artery and the pump console. This particular device is introduced via internal jugular approach. The device reduces cardiac volume overload and also filling pressures. Multi-center prospective single-arm study was completed in 30 patients, and the device was used between 12 to 24 hours. The primary endpoint was composite of major adverse events through 30 days. As we can see, freedom of major adverse events was 100%, technical success was high, 97%, and right atrial pressure decreased by 34% from baseline, and pulmonary capillary wedge pressure decreased for 27% from the baseline, and urine output increased for 130% from the pre-treatment value. Another one is by Magenta Medical, TRVD, or Transcantarenal volume decompensation, which is related to the decrease in venous pressure that reduces renal venous preload and afterload. First in man was completed in 2019 in 13 patients, and in this particular study, renal venous pressure was decreased from 19.2 millimeters of mercury to 4.1 millimeters of mercury at 23 hours of use of this device. Another interesting device is a CPNS device that consists of a catheter technology and nitinol braid in the pulmonary artery that has a neurotransmitters and neurostimulation electrodes and two pressure sensors. This device is positioned in the right pulmonary artery and is introduced via internal jugular vein approach. It stimulates paracardiac and pulmonary systemic nerves. It increases cardiac contractility without increasing the heart rate, and improves cardiac output and renal blood flow. Early feasibility study was done in 2021 with encouraging results. The future device that has a certain similarities to Impella is Magenta Elevate device. Of course, this device is also experimental and it's not available in the United States. It's catheter-based technology that uses axial flow pump. It's a significantly lower profile device than Impella. It's a 10 French device introduced via femoral artery approach. It has a self-expanding impeller, which is comprised of thin memory-shaped metallic frame and flexible material that forms the blades. It can pump more than 5 liters per minute of flow, and it, in future indication will include high-risk PCI and cardiogenic syndrome, and first-in-man study was completed. Now, interesting group of devices, which we call pushers, are placed in the descending thoracic aorta, and they include CardioBridge, Aortix, and second heart assist device. All of those devices have certain benefits, and the rationale is for percutaneous use of these devices to avoid crossing the aortic valve, we avoid risk of stroke, and it's located in proximity to the kidneys to improve the renal blood flow. And as we can see, this is based on differential of the pressures between above the device and below the device, where the pressure below the device is for 10 millimeters of mercury higher than above the device. Aortix by Precardia is a temporary microaxial flow device that has an optimal speed of 25,000 RPMs. The aortic fixation is achieved by 4 anchors, as we can see here. It's placed in the upper descending aorta. First in man was used for PCI in 4 patients at increased urinary output in all of the patients studied. It's a 16 French delivery system via femoral approach. EFS was completed in the United States in 20 patients, and pivotal trial is apparently starting soon. Another interesting device is second heart assist device that has an open cage design. It occupies the entire aorta in the descending thoracic aortic location. It is affixed by radial fixation. It consists of impeller-driven pump, and the optimal speed is significantly lower than with the other devices, somewhere in the range between 7,500 to 10,000 RPMs. It provides additional 2.5 liters of blood flow. and it also offers up to 50% increase in renal blood flow. First in man was completed with evidence of 400% increase in urinary output in patients that underwent high-risk PCI. So, in summary, the use of PVADs continue to increase for high-risk PCI and also for patients with cardiogenic syndrome. Multiple devices are available with increasing level of systemic flow that might be required in certain scenarios. Current PVADs deficiencies, however, include technical complexities for certain ones, need for LV access, and the risk of hemolysis. Several venous decongestion peripheral assist devices are emerging and offer promising preliminary results. Temporary PVADs located in a descending thoracic aorta offer several benefits in comparison with the others, and the indications in the future will include patients with high-risk PCI, elective PCI in chronic renal failure, and also acute decompensated heart failure and cardiorenal syndrome. Thank you very much for your attention.